All right, good morning and welcome to a special edition of Virtual Face-to-Face with President Bruce Jarrell. I'm Alex Lukowski, Executive Director of Media Relations. Alabama, Arkansas, Kentucky, Missouri, Oklahoma, South Dakota, and Wisconsin. Just 5 days after the Supreme Court overturned American women's right to abortion, these 7 states have already made the procedure illegal. Now, that number will jump to 16 very soon, although legal challenges may slow things down a bit. And 6 more states will implement laws that impose restrictions, banning abortion in some cases after just 6 weeks of pregnancy. And a handful of others are already becoming battleground states for state legislatures, including Michigan and Pennsylvania. All told, in the near future, 26 of the 50 states may impose strong restrictions or outright bans on abortion. Now, Maryland, as we know, is not one of those. In fact, Maryland has among the strongest abortion rights protections. But that doesn't mean we won't feel the effects. Local abortion providers expect an influx of out-of-state patients, and funding is already pouring in to help providers manage, including $300,000 from Baltimore Mayor Brandon Scott. Of course, we don't know the full impact yet, but there's plenty of evidence that it's going to be widespread, manifold, and will disproportionately affect women of color. Black women in particular, who already suffer from an array of issues stemming from long-term structural racism. I'm talking about poor health conditions, lower incomes, lack of health insurance, and access to good health care, including, of course, prenatal health care. The CDC says black women are 4 times as likely to seek an abortion as white women, and black people are a larger part of the population of most of the states that have already banned or are set to ban abortions. The Kaiser Family Foundation points out that in Mississippi, for example, black residents make up 38% of the population compared with 13% of the national population. As a result, black women account for about 3/4 of the abortions in that state. Unfortunately, many of the states moving to ban abortion have also the fewest social services available for mothers in poverty. The Census Bureau says Mississippi has the highest percentage of children living in poverty and the lowest birth weights. Texas has the largest percentage of women who receive no prenatal care in their first trimester. A study in the journal Demography predicts a 21% increase in pregnancy-related deaths, 33% among non-Hispanic black women, simply because staying pregnant is more dangerous than having an abortion. Additionally, the World Health Organization says 23,000 women around the world die each year from unsafe abortions, and diminishing access to safe and legal medical care seems likely to drive that number higher here in the U.S. And consider these findings of a Middlebury College study. In all of the states expected to ban abortion, about 1/4, if they all do that, about 1/4 of American women of reproductive age would live at least 200 miles from a legal clinic. That is a terrible hardship for many women and a practical impossibility for many more due to cost, access to transportation, childcare, and time away from work. What's more, just being able to get to a clinic doesn't guarantee you can get an appointment. Expect demand in adjoining states where clinics can legally operate to grow. So what happens if millions of women are compelled to maintain a pregnancy to term? Well, just look at the changes that occurred after Roe v. Wade legalized abortion in the 70s. The teen birth rate dropped by 1/3. More women pursued higher education, had longer and more productive careers, and were much less likely to end their lives in poverty. UCSF's landmark longitudinal Turnaway study followed more than 1,000 women across the country who were denied abortions, mostly because they sought care beyond their facility's gestational limit. They found that women were less able to pay basic living expenses, more likely to experience bankruptcies and evictions, and more likely to stay with a violent partner. They also experienced more mental health issues, often impairing maternal bonding. There are so many other health and non-health related issues here that will have to be decided state by state, such as availability to medication-induced abortion, legality of travel to states that permit abortion, the status of social services that mothers need, like childcare and paid family leave. A few weeks ago, we talked about the legal side of things, and we may talk about those legal issues again in the coming weeks because there's still a lot to untangle. But today, we're going to talk about the health impacts on women of this ruling, and also how we might best serve our students and their future patients and clients. And to do that, Dr. Jarrell is joined by 4 members of our faculty today. Nadine Finnegan-Carr is a research associate professor and director of the Prevention of Adolescent Risks Initiative at the University of Maryland School of Social Work. Her SSW colleague, Stacy Stevens, is director of Be More for Healthy Babies, a highly successful initiative combating the infant mortality rate here in Baltimore, and a part of the Promise Heights initiative. Dania Cato is assistant professor and director of the Pharmaceutical Health Services Research Graduate Program at the University of Maryland School of Pharmacy. And Jessica Lee is assistant professor in the Department of Obstetrics and Gynecology and director of family planning and the Ryan Residency Program in Abortion and Family Planning in the University of Maryland School of Medicine. Welcome to everyone. Before we do get started, I want to remind the audience that this program is being recorded and will be posted later on the UMB homepage. And later in the program, the audience will have a chance to ask questions. Please write your questions in the chat area. And when the time comes, we'll call on you by name. I'll open your mic for you. All you have to do is speak up. And if you'd like to remain anonymous, of course, that's okay too. Just let me know. And with that all out of the way, let me introduce your host, UMB President, Dr. Bruce Jarrell.
Greetings to all. It's a great pleasure to be here. I want to begin by thanking our highly expert group of panelists. Thank you for being here. For the audience, we've had a record subscription to this particular show, so thank you for that. I do want you to keep in mind that the topic is the impact of the change in federal law on pregnant women as you put together your questions to send to Alex. But please, get your ideas in mind for questions now. I also wanted to just spend 1 minute on the Maryland law, which I've been studying for the last couple of weeks. And I wanted to really read to you so that we do understand in Maryland what the landscape is. And that is, it is legal to perform an abortion up to the point of fetal viability. The law does not define gestational age at the time of which time the fetus is viable. It is defined by in the best medical judgment of the attending physician. Maryland law also allows abortion later in pregnancy when the life and health of the mother is threatened and for severe fetal abnormalities. And our panelists may enrich this definition as we go along, but I wanted to read that to you. This law was passed into law in 1991 by the legislature. It then went to a state voter referendum, and the voters ratified this in 1992 with a 62% approval. So there was strong support for this in the state of Maryland. Some of you will also recently have seen that the legislature just recently authorized abortion to be performed by other health care providers in addition to physicians, and provided funding, which will be realized in a year, for additional education for those providers to make this a safe procedure in Maryland. So with that background, and again, our panelists can add to it as needed, I'd like to start out with a question for Dr. Lee. Jessica, put yourself in the practicing OB. You're practicing OB in a state like Mississippi, which has banned abortion. What are the 1 or 2 medical situations that would pose a high risk to the pregnant woman that you might encounter? And how would you deal with that situation today in Mississippi as opposed to 2 weeks ago? Give us some insight into your medical thinking and what will change in that state, please.
That's a great question. And I want to honestly just say I feel for my colleagues in Mississippi who have lost the ability to stay true to their oath to provide the best care possible to their patients. And, 2 weeks ago, Mississippi only had 1 abortion clinic as it was due to the already difficult landscape in that state to provide abortion care. So honestly, I think they're already struggling greatly before then. But say we have a patient who comes in pregnant and her water breaks too early. That is sometimes, often, if it's too early, incompatible with fetal, the baby developing their lungs. And it also opens up that patient for infection. So we call that preterm rupture of membranes. And we're often left as their doctor to decide, where do we go from here? Some patients will want to continue the pregnancy at whatever cost, but some patients may start to develop signs of infection, and we have to make a decision regarding how to manage, because the cure for infection is to remove what's infected, which is often the pregnancy. So I would see my colleagues being faced with a very difficult decision on when they can intervene. I know my colleagues are struggling with worrying about being sued or being prosecuted if they intervened too early? Did they not show that the maternal health was at risk enough to perform this abortion? I see it becoming very sticky to uphold our duty to take care of our patients if we're worried about the law hanging over our heads. So I really feel for my colleagues, because these are situations that, though are less common, do happen. They happen probably once or twice a month, even here. Another common condition that can affect patients early in pregnancy is preeclampsia, which is a blood pressure disorder of pregnancy. The cure for that is also removal of the pregnancy or delivery of that pregnancy. And I've seen patients even here in Maryland who developed the life-threatening version of preeclampsia, in which they actually lose their ability to even clot their blood. And at that point, we definitely recommend delivery or termination to save their life. And I can't imagine what it feels like to be a Mississippi OBGYN or someone providing OB care and not having to be able to make that decision sooner if they could, being worried about whether they're acting with accordance of the law when the mother's health is truly in danger versus not. I wouldn't want to have to make that call as a physician.
And you're in Maryland now, and if you were faced with those two situations, has anything changed since the Supreme Court decision?
No, in Maryland, we have our ability to provide abortion for the reasons you stated earlier. That has not changed at all. And we have our ability to care for patients, I think, in the correct medical way we should.
Terrific. That was a great two examples, and I appreciate those. Let me move on just a little bit here to Dr. Finnegan-Carr. Nadine. Nadine, tell us about your program, particularly as it relates to teen pregnancy, and then put yourself in one of those states banning abortion. What impact, what problems, what kinds of issues do you see coming up with this new ruling in another state, particularly where you're dealing with adolescent women population?
Yes, thank you. Thank you very much, Dr. Jarrell, for your question. So first of all, the Prevention of Adolescent Risks Initiative here at the University of Maryland in the School of Social Work, what we do is that we provide training, support, and we've even developed curricula for adolescent reproductive health here in the state of Maryland. We work directly with the Maryland Departments of Health to provide that curriculum in among youth that are in child welfare and juvenile justice, as well as we have several programs that work with young people who have been victims of human trafficking, including child sex trafficking. And so our work primarily focuses on that. But when we work with young people talking about their sexual reproductive health, part of both the curricula that's designed for the youth themselves, which is called Power Through Choices that we've offered, as well as the training for child welfare professionals and juvenile justice professionals and health professionals that work with youth, we make sure that we talk to them about all of their contraceptive issues and including abortion as an option if a pregnancy occurs, because they're at the stage where they need to learn about it. They don't even know what contraception to use to prevent a pregnancy. And so that is what we have been doing. That is what we've done. We have the benefit right now of being in Maryland, where youth have access more than in some of the other states to clinical care for prevention of a pregnancy, as well as if they needed to. But one of the things that we need to understand is that adolescent women, regardless of what state they're in, actually have the lower end of abortions performed in this country. For adolescents that are under the age of 15, it's like 0.2% of adolescents under the age of 15 have an abortion. The majority of abortions among adolescents are in 18 to 19-year-olds. Among those who do seek abortions, it's about 70% of adolescent abortions occur in that 18 to 19-year-old range, which is the age of majority here. The issue that we have in Maryland is when our laws require parental notification if it's safe for the child, but it does not require parental approval. So if a young person does want to go in, and that's part of the even giving them their options for contraception, is letting them know that that's not a barrier. Because for some, a barrier is, how do I tell my mother that I want to get an abortion? In most cases, believe it or not, they still want to notify a parent. And there is still a parent that is notified. It's not that we're, people are willy-nilly, but it's taking that burden off of them that, oh my God, I don't know how to get her approval, to say, you don't actually need her approval, but we're going to have to notify one of your parents, and walking them through that in the context of giving them all of their contraceptive choices is what we do. We're not advocating for one way or another. We're literally saying we're trying to prevent it before it happens and advocating across the board. The concern that I have, especially if we were in another state, especially one of the states with the trigger laws that has either already moved to ban abortions or will be doing so in the next few weeks very quickly, is that the majority of those states are also the majority of the states that have the highest teen pregnancy rates. And so we all already have issues with adolescent pregnancy in those states, and now it would be increased even more. So, for example, for Mississippi or Louisiana, they're already number 1 and 3 of the teen pregnancy rates here in the U.S. So if I were talking to an adolescent there, they now already were at risk for having a pregnancy as an adolescent. They already had limited options for prevention in those states. And now they also have, and they were already limited because of their strict rules as it was for receiving an abortion. And now they even can't do that. And so we have literally, unfortunately, put an undue burden on adolescent women in those states that exceeds what was already a negative situation when it came to adolescent pregnancy. And so I have colleagues that are currently working in Texas who were worried before this was overturned. Social workers at the, who were trained at the University of Texas, Austin, our compatriots there in Texas, who are worried that they are going to be arrested for even saying and recommending abortions for high-risk pregnancies that they're counseling the mother when she was making that decision. They were already worried about that. And now across the board, they can't even provide that as an option.
Thank you for that, Nadine. Stacy, let me move to you. Stacy and I had the great pleasure of presenting the Be More Healthy Babies results in West Baltimore with the mayor. What was that, a year ago, Stacy? And they were fabulous results, showing that infant mortality can really be influenced by an extensive program of building trust and a network and a number of other things, which Stacy can mention to you. But Stacy sees firsthand the amount of effort that it takes in West Baltimore for young mothers to have a successful pregnancy, a safe pregnancy, and then have a healthy baby. And it has taken a lot of trust building, hasn't it? So would you tell us about your success in Baltimore, but then extend that to a disadvantaged community, say in Mississippi or Kentucky, where they banned abortion? What do you predict will happen for these young mothers who want to carry their baby to term, or for those who want to terminate their pregnancy? What do you think is going to happen in states like that?
Thank you so much, President Jarrell. I appreciate the question and the opportunity to share once again the long work and arduous work that Be More for Healthy Babies has done over the last 12 years within Baltimore City. And that work has largely been focusing on reducing the infant mortality rate. But we know that in that, we cannot exclude the mother, the woman, because the woman's health is linked to infant health outcomes. And so what we have done through Be More for Healthy Babies citywide initiative, which is led by the Health Department and the Family League and Healthcare Access Maryland, and more specifically in the communities of Upton and Druid Heights, and led out of the School of Social Work Promise Heights and also the School of Medicine. Dr. Wendy Lin is our epidemiologist. What we've done is we've really focused on a collective impact model, and that's what it takes. It takes a concentrated effort at looking at all levels of systems for women and applying a life course perspective. So not just looking at what's happening with a woman at the point of pregnancy, but we're interested in backing it up all the way to when her mother was pregnant, because some of those factors are impacting that woman's health and pregnancy outcome. And so we are working with women and meeting them in the community where they are, assessing their chronic stress levels, looking at and being very clear about the social determinants of health, which is what I talked to you about last year at this time, really talking about how that where a person is born, that woman is born, she lives, she works, she worships, she plays, and where she ages, and how that lived environment with those social conditions are contributing factors to that woman's ability to conceive and carry successfully. And then also as she interfaces with her community, right? And as she interfaces with other providers, with medical providers, with folks in schools, how in accessing that, is that contributing to additional stress on that mother? And as we're seeing, when we're looking at the key drivers of maternal health outcomes in Maryland, it is hypertension, chronic hypertension, gestational hypertension. And so that really speaks to that weathering that's happening on a woman's body and setting a woman's body up for not being able to carry a baby to term or to have a baby earlier. And then, of course, we're assessing all the resources that she has access to. We're shoring her up in the resources. So we're making sure that she doesn't have any barriers to care that may cause delays in receiving adequate care. So we are addressing transportation. We are addressing food and nutrition. We are addressing ensuring up her support system, which is critical as she is navigating, critical as she is carrying her baby to term or making a decision to abort that child. And it's a decision that may not, is not taken lightly. But so we are aware of all those factors. And then, of course, looking at what's happening with policy and the financing of services through insurance. And so we're really fortunate here in Maryland to have adequate funding to support women through medical assistance, expansion of medical assistance options, Title X funding to make sure that folks have access to fantastic family planning and what have you. But what I'm saying is that it takes this concentrated collective impact model across systems over a period of time. That includes not just the medical providers, it includes community health workers, it includes doulas, it includes public health workers, everyone who's on the call, pharmacists and what have you, in supporting that woman in making the decisions about her healthcare options and accessing full spectrum reproductive healthcare, which abortion is included in that. So we cannot deny that, abortion is one part of that. We're talking about comprehensive reproductive health care. So that's important to mention. And so when we're looking at what's happening with our colleagues in Mississippi and Kentucky, I pulled up the March of Dimes, prematurity birth report card, and they're both getting grades of F and pretty much D. And a lot of that has to do with those that social vulnerability index that really speaks to, again, those lived and built conditions. I can't stress enough how stress plays and impacts racial health disparities that we're seeing, why Black women have to access abortion more. When they do so, their health is in poor conditions. All of that has implications to accessing abortion care and reproductive health care options as we move forward. So really, we're really needing to say that we need to address those social vulnerability indexes, which are embedded in the structures. And we've been talking about this for quite a while. Embedded in the structures of food access, of housing, of education. And we're talking about education, we're talking about health literacy. So making sure that we're explaining, information of this matter in a way that our clients can understand it, comprehend it, and then move it within the body of who they need their support team, their support structures, their family, so that they can make a decision about what they want to do with this pregnancy. And so in that support network, it may be community health workers, it may be clergy, and it definitely may be the father of the baby, and it's also their other family members. All of those family members are critical in supporting not only this decision around making abortion, but also as a woman continues to navigate through her pregnancy and also in parenting. And research has proven how key influencers fathers are, and that support network is as being protective. So yeah.
Thank you for that, Stacy. And you all got to see what passion is really about in terms of making our West Baltimore community better. Thank you for that, Stacy. Last in our panelists is Dr. Cato. Dr. Danya Cato is in the School of Pharmacy. She's really an expert on the pharmacy interactions with the whole women's health environment. And of course, she also knows a lot about contraception as it relates to pharmacists. So please, Dr. Cato, tell us about your interests in this topic, and also comment about the state of contraception in other states, what's available, what's funded, et cetera, particularly those that are banning abortion. Dr. Cato.
Thank you, President Jarrell. I want to first and foremost thank you for convening this panel and for inviting me. I want to enthusiastically +1 everything Stacy said, especially in terms of centering the life course of women above and beyond pregnancy. Women are not just vessels for reproduction. They are full human beings, and in order to care for their health, we need to address the totality of their care needs as human beings. I also just want to point out something to consider in terms of framing, and that is that the reversal of Roe versus Wade does not only impact women, it impacts young girls and trans people, both in very direct ways. So I want to encourage us in the spirit of equity to expand our language to be inclusive in order to appreciate the diverse ramifications of this decision for a lot of different communities. To your question, President Jarrell, I'm interested in the topic because I believe healthcare is a human right. And in as much as reproductive care, including access to safe abortion, is healthcare, so I see the question of access to reproductive care as a right as well, and as a matter of justice. A matter in which many organizations, primarily led by Black women and Indigenous women, have been working on for decades. They have been at the vanguard of bringing these questions to light and thinking of that big picture, holistic healthcare question that Stacy just brought up. Pharmacists, as the most accessible of healthcare providers, can really be at the center of this fight for reproductive justice, and I feel that strongly, and that includes access to contraception. In previous surveys, 1/3 of US adults report trouble accessing contraception, and these rates are even higher among Black women and other women of color. To help enhance access, in 2017, the state of Maryland passed legislation that broadens the scope of pharmacist practice to include hormonal contraceptive prescribing, thus broadening access to contraceptive therapy. I was one of the pharmacist members of the Maryland Board of Pharmacy Commission on Access to Reproductive Health stakeholder work group that really helped operationalize the rollout of this law that legalized pharmacist prescribing of contraceptives. Unfortunately, without critical support, not too many pharmacists have taken up this charge. I'm really interested as a health services researcher in understanding why, what barriers are at play, including the ever-expanding roles and responsibilities of pharmacists without adequate compensation and support, as well as inadequate training. In terms of the Supreme Court decision, it does not directly affect access to contraception. However, we know this now that medical and legal experts are very worried and anticipate that states, counties, or even individual prosecutors who want to ban Plan B, also known colloquially as the morning after pill, may now believe they have this, tailwind of support from the Supreme Court, and may begin prosecuting that. And that's a part of this discussion. Obviously, this is one of what I hope are many discussions we have on campus that may also include legal scholars to think of the role of this reversal in terms of continued surveillance of women, young girls, trans people broadly, and criminalization of pregnancy, and using pregnancy as a potential justification for expanding the prison industrial complex. And we really need to make those linkages concrete, because we see it play out in states that are now and have already trigger banned abortion. So just to say broadly that although the Supreme Court decision doesn't directly affect contraception, a whole host of legal, medical scholars and clinicians are extremely worried that the ripple effect will affect access to contraception.
Fascinating perspective, and one that I don't think we consider every day. But to answer one of your questions, we do hope to have our legal scholars back online here. I've had many discussions. It is a fascinating topic, no doubt about that. So we're half an hour into this, so it's time for the audience participation. Alex, do you have a couple of teed up?
We have a lot of questions, as you might imagine, and grouped in a few topics. One topic is, we've been talking about educating clients, but there are a lot of questions about educating our students, the next generation of providers. Let's bring in Adam Schneider. Adam, go ahead and ask your question.
Hi, thanks so much for this program and to the presenters for your time, your expertise, and all the work that you're doing. Given that Maryland's abortion protections and infrastructure will be even more critical in the months and years ahead, what I'm really curious about is how UMB is and is planning to train more abortion providers, and how we're working with the University of Maryland medical system to build abortion infrastructure and access within broader health centers such as the University of Medical Systems. When you look at their website and you search for abortion, it says that the term can't be found. If you look through the services that are provided, it isn't listed there. And I think one of the strategic mistakes that was made by the heroes of the past is to have abortion care too often provided outside of larger healthcare facilities and centers. And so I'm hoping that we can address this by further integrating abortion services within the healthcare, within broader healthcare and centers. So that's a lot to take on. But again, appreciate any thoughts that you have and direction that the school and or that the university and the University Medical Systems is going to and is planning to go. Thanks.
Thank you. Jessica, that may be a question that you'll have some knowledge about, but I'm not sure we can answer it all yet.
Well, I want to just echo the fact that I think when Roe versus Wade was first passed, it was the hope of many physicians and medical professionals in the country that abortion would be less stigmatized and happen more often in our hospitals. But we've found that simply is less the case. We know that outside clinics provide the bulk of the care and do a great job and a safe job of providing that care. But that being said, University of Maryland does offer abortion care, working on website presence as we speak, so that we can be more easily discoverable while keeping our staff safe, which is another concern we've always kept as a huge point of importance. And in that vein, I just want to emphasize that we provide full spectrum care at the University of Maryland Medical Center OBGYN department and family medicine department. And I deliver babies, I provide abortions. We consider that all part of crucial care. That being said, I run our hospital-based abortion clinic, and we provide excellent services. So please make that known that you can refer your patients to us, and we are always happy to help. And then we can talk about training if you want me to interject quickly there. All to say is that our residents and medical students get exposure to and excellent training if they're residents here and want to participate fully in abortion care, which I feel is crucial to being a full spectrum OBGYN. And we do we do think about whether we have the capacity to take on out-of-state learners. We haven't really been in those conversations yet. My priority is obviously the residents that work here day to day, as well as our medical school. But I would have to imagine we need to think broadly about that at some point. It is our duty to think about that.
I would like to answer that
Oh, I
question
was
as
going to jump
well.
in too.
Yeah, and thanks, Adam, for that
Okay,
question.
a minute each. How about that?
Okay, a minute. I just want to stress the importance of accessibility. And sometimes having it in a hospital makes it harder for community members to access. You know, on bus lines, how many buses do I have to take? You know, I'm off work, what have you. So we have to consider that. And so again, looking at this whole thing around thinking about full spectrum reproductive health, we need to offer, you know, that available easily in the community so folks can receive those services as they need it across the country. And then we want to talk about also, as I'm thinking about this question, about the amount of violence that we have seen at those sites. And so trying to figure out how to address that and make sure that folks are not defacing and harassing folks as they are trying to access medical care.
Gotcha. Nadine?
And jumping in, that's perfect in terms of making sure that there's access in the community. The Maryland Assembly actually this year, April 2022, in advance of and in anticipation of the Supreme Court ruling, actually passed the Abortion Care Access Act. And that act allows for a broader range of healthcare workers, nurse practitioners, nurse midwives, specifically physician assistants, to perform abortions, and allocates $3.5 million to pass through the Maryland Department of Health, which we might want to, as a university, look into, to train healthcare workers to be able to perform abortions in the community. It also has some requirements that expands access using healthcare insurance and things of that nature. And this legislation was enacted, and it was enacted in a way that they wanted to make sure that there wasn't a gubernatorial override, which there wasn't. So it's in place, right? It's going into place because we need to make sure that even though we want to make sure the university, as the university hospital system, the students in the university medical center have access, but we also do have to me, I'm compelled to make sure that our overall community in Baltimore and our overall community in Maryland, as we're the University of Maryland, we train the majority of the medical professionals in our state, have access to a broad spectrum of complete sexual reproductive health services that includes contraception and access to abortion. And I think I did that in a minute.
Great. Okay, that's great. Alex, how about another one?
We have a flood of questions. Several questions are expressing nervousness about it's the threat of access in Maryland, but also outside Maryland, to everything from IVF and medication abortion, but also just contraception. I'm going to bring in Lana Haney, who is one of those questioners. Lana, go ahead.
Hi, thank you. I just wanted to get some clarification on what, if any, will the overturning of Roe v. Wade have on access to contraceptions, whether it be like IUDs or birth control or Plan B. So yeah, that's it. Thank you.
Right. Big differences there, right? I mean, in those potentially legally.
I know they were talking about like CVS is pulling them out of stores in some places, but on a legality side, it's not really talked about like fully like in states, but it's a lot within our generation. People are getting very scared and nervous about it.
Anybody want to comment on that in the panel? Please, Nadine.
Okay. In terms of the legality of that, and in terms of the access pieces, especially since contraception, a good bit of that falls under Dr. Cato. So I'm going to let the pharmacist part of that come back to you. But what I will say, what I'm concerned of in our state, even with good access, and good being in air quotes, I'm also concerned because we have less than half of the clinics that offer contraception as well as abortion in our state than we had in 1982. In 1982, we had 52 clinics across the state that offered broad spectrum contraception and abortion, and we're down to 25. 67% of our counties in Maryland don't have an abortion clinic. So even though we have good laws, we don't have good access as it is. And so it is crucial that, at least here in our state, that pharmacies, and I was glad to hear Dr. Cato mention the changes in the law as far as pharmacists being able to prescribe some of these contraceptives without, having to go through other means. But it is still an issue. I think some of it for us now is going to be messaging and getting the message out that you can get this from your pharmacist and it's totally legal, because of the fact that people don't necessarily have access, especially in rural areas of our state. Our adolescents, even when we speak to them about what they can do, they then don't have a Title X clinic to go to get it. Depending on where they're living. We're lucky in Baltimore City to have the access that we do. Other parts of the state do not. So I'm hoping, Dr. Cato, you can go ahead and jump in with the pharmacist end of access, but it is problematic in our state.
Please, Dr. Cato.
Thanks, Nadine, for that. First and foremost, to the person who asked the question, I just wanted to say that you have every right to be concerned. People are concerned about the potential ramifications of this decision in terms of access to birth control and access to Plan B and IUDs in particular. One thing that I want to caution against is conflating Plan B and IUDs with abortion. They're not abortion, and they're often conflated strategically to stoke some of these, what I would call oppositional forces to reproductive justice. So I just wanted to say that first and foremost. But the Supreme Court decision does not directly affect access to contraception. I think what my sort of recommendation would be is to continue to hold your state representatives and legislature accountable to ensure continued access and to mobilize collectively, including with colleagues that are in states that have enacted this new legislation and these new bans, and to work and think collectively about how we can codify reproductive justice as part of the law.
Thank you. Alex, let's go to a next one.
All right, I'm seeing a lot of questions about the status of how things work in Maryland. I want to bring in Erin McCleary, who's, I think, is asking specifically about something that happens in the hospital system. You may not be able to answer this, but because we're not UMS, we're the University of Maryland, Baltimore. But she raises a point about how things work. It's not as simple as we might think. Erin, go ahead and ask your question.
Hi. Yes. So I work in women's and children's at the downtown campus and treat many children with several cardiac anomalies. And it's come to my attention that after the 20-week anatomy scan, if there are several life-threatening anomalies found or diagnoses of the fetus, if the mother is considering an abortion at that time, that they are required to sit before an ethics board. And I just wanted to understand that decision a little bit better and the, kind of the reasoning behind it, since it is already such a difficult decision to make for that woman and their family. Thank you.
Jessica, any knowledge about that one?
So I think right now the process of termination thresholds at University of Maryland is being reviewed, and I think a more formal statement will be put out in a few months. But as it stands, a person wanting to have a termination all the way up to 20 weeks for any reason, we will be able to care for in our hospital-based abortion clinic. But because of resource limitations and needing operating room time, after 20 weeks, we generally will review the case. Ethics generally gets involved. It's after typical viability 24 weeks. That's the broad way we approach it. We try to be as equitable and fair, but also knowing that many other outside clinics also provide excellent care using a lot less resources than we do as a giant hospital system. So we're always able to make referrals for patients that we cannot help, and it's a process that's currently undergoing review.
Thank you. Alex?
Many of our members of the audience are looking for ways they can help people out of state, and also expressing some concern about providers who are helping people from out of state. We have this anonymous question: how is Maryland going to protect providers with out-of-state patients? Some states are attempting to criminalize lawful procedures performed in other states. Is that something that's on the radar?
I don't know that any of us are expert to address that. I would say to you that there's a lot that's got to play out. That's going to be one of them. And as you read the literature being published, you see that over and over again, but you also see, no, they can't do that. So I think I wouldn't want to render an opinion. I think we have to stay tuned on those kinds of things. We do not want a penalty for people in Maryland to do something that's legal in Maryland.
Right. We have, this program is being live streamed on Facebook and also on LinkedIn, and we have a LinkedIn questioner who is from Minnesota, from the Minnesota Department of Health, and she writes, does the university intend to advocate for the training of abortion providers in light of what she says that Governor Hogan recently decided to withhold funds for that? Without the politics involved, is it something we're talking about? She's asking, are we thinking about providing more training for abortion providers?
I don't have discussion about that. Jessica, do you have any knowledge, or anyone else have knowledge of that?
So in general, our duty is to train our residents and medical students, definitely as a priority. But in that vein, my inbox is actually filling up at this moment for traveling residents who are interested in training with us. And it's already been a discussion since Texas passed their Senate bill last year. We had opportunity to bring in a visiting resident this past year. It's not going to happen overnight, though. We don't have a ton of capacity. We are also wary of the fact that, these residents can be trained here, but who upkeeps their skills once they head back to their home institution? So I think it sounds great, and I think there is some duty and responsibility to train out of state. But really what we need is those states to just be able to provide abortion to begin with. And also, I just want to echo that Maryland has many, many abortion providers, particularly Baltimore. I welcome people who are interested in getting training. What we need is people on the Eastern Shore. We need people that in places that don't already exist. And I love the enthusiasm and eagerness of people coming out of the woodwork, wanting to help. And I want to encourage that. But we have a great infrastructure already. What's going to take time is getting more OR time, getting more slots, getting more supplemental staff, and the timing of COVID burnt out, people finding other things to do with their advanced degrees. So there's so many things confluencing into this time that are hard. We're in the midst of COVID still. So I think we're just trying to be mindful that training is important. What you do with that training and where you go with that training is also important as well.
Okay, thank you, Jessica. Alex?
All right, I did not expect this question. I'm kind of glad that it did come up. I'm going to bring in Catherine Robinette. You know her. Catherine, go ahead. Dr. Robinette, are you there?
Can you hear me now?
Yes, there you go.
Hi, I
Wonderful.
apologize. So my name is Catherine Robinette. I'm pulmonary critical care, but also the soon-to-be president of the Women in Medicine and Science group. One thing that I'm really interested about is if there's any ideas that any of you have about talking about the impact on men. I feel like us women have been fighting for this in all of our voting years. There's a lot of minimizing of it over the years, that we're just focusing on gender politics. And I think to truly be effective, we need to talk about how men are impacted as well. Clearly, it's female presenting individuals whose lives are at risk and who are most impacted, but maybe some talking points about how this lack of access to basic healthcare for half of the country impacts men.
That's a tough one, Catherine, for me to answer. I have to say that I've been married for a long time, and I would have never thought about my wife as separate from me when we talked about things like this. It was a team that was discussing it. Now, I'd also say as a practitioner, I have personal convictions just like anybody else, and this decision affects those as well. I don't know that I can go any further, though, in thinking about your question without more time. Anybody on the panel have any other thoughts, realizing that you're non-men?
I'll comment just from the work that we do with Be More for Healthy Babies. We have always made space and included men in the discussion of pregnancy outcomes, and how they operate as key influencers of behavioral health that impact maternal and infant health outcomes. And those are around breastfeeding, smoking, reduction and cessation, and so also around nutrition and care and early entry into prenatal care. So that's really critical, and we need to know that the literature shows that. We have seen that. And so I think it's an interesting question because there's like a narrative, and all of this is about a narrative, about what narrative is put out there and who puts it out there. And so, I didn't mention racism being, very much a part of all of this conversation and decisions and outcomes, but we have to be careful around a deficit and a very narrow lens about male involvement and their support. They, as I mentioned earlier, are key influencers of maternal and infant health outcomes. They can be included in helping and supporting partners in making that decision. As difficult of a decision as it is, they can be involved in providing payment and support for that decision if insurance is an issue. So again, when we're talking about any of these topics, sexual reproductive health education, we must include boys early on, K through 12 health education, so that they can know the integral part that they play around their bodies and as they are in relationship and partners with others, and their role in supporting better health outcomes for themselves and others. And I hope that answered your question. They are critical. It's key, and it really is about the narrative that's being put out there, right? The spin, and I'll just be clear, it's a white feminist perspective. And so again, when we're talking about what Dr. Cato mentioned earlier, really pressing and understanding reproductive justice, which has been coined by Black and Indigenous women, we're talking about health being a human right to maintain personal bodily autonomy, to have or not to have children, and to parent the children we have in safe and sustainable communities. When we look at that larger framework in that model, we can see the role of partners, transgendered, and also men in making those decisions. So I hope that was helpful.
That's a tough one. I'll have to keep thinking about that one. Alex?
I'm going to bring in Frank Rath here. Frank is asking sort of about the status of abortion in Maryland. Who's getting abortions and why? Frank, are you there? Frank,
yeah, here, thank you very much.
Yeah, go ahead, sir.
First, I wanted to thank you and the entire panel. This has been a real learning experience for me. I think the whole issue of abortion is certainly very emotionally charged, and I'm keeping an open mind about the whole thing. Just a little background, my mother was a OBGYN nurse practitioner at a Planned Parenthood in the 80s and 90s. So I kind of grew up with that. I understand the fears about providers being potential victims of violence, whether verbal or otherwise. And yet at the same time, I feel a little conflicted because what I haven't heard is any discussion about the rights of the unborn child. And this is where I start to get a little internally conflicted and recognize that the issue is extremely complicated. that there are lots of reasons why somebody might get an abortion. And I think that's part of what I learned here today. And that's why I'm asking the question about the etiology of abortion. Like, how many abortions are the result of complications during the pregnancy that that now the woman's life is at risk, versus how many are just simply the result of, for lack of a better word, poor decision making, because part of the woman's decision, assuming they haven't been the victim of a crime, is having unprotected sex. So, you know, again, I'm not necessarily advocating one way or the other. I'm trying to learn more, and I'm interested in hearing some different perspectives, and learning more about abortion in general, because I don't want my own feelings to be driven by emotion rather than understanding the facts and the scope of the whole problem.
Before I go to our panelists, for all of the audience, this discussion can go a little past noon, so we don't have a hard cutoff right at noon, so we can get to one or two other questions. With that question, who would like to try to address that one? Nadine.
So, the United States teen pregnancy rate right now is roughly about 17 per 1,000 live births. So I'm just giving that as a frame. 46 abortions per 1,000 live births, which is more than the teen pregnancy rate for the United States, are of married women. Let me repeat that. 46 per 1,000 live births are for married women, women who are legally married in the United States. So if we're going to go, I just want to get into that. So if we're talking about that, and we're talking about unprotected sex, of 46 women per 1,000 live births who are in legally heterosexual married situations. So when we try to set up an argument or a statement that, people had unprotected sex and then they got pregnant and then they went and had an abortion, you're also talking about married women. You're not just so this is not an easy question to answer. And I wanted to specify that. And also another thing to think about is the majority of women who have abortions are already mothers. And so when we talk about this being a part of a comprehensive sexual reproductive health choice, these are not women who are taking this lightly. These are women who already have a child, who have already, if you really want to say that motherhood is the mark of a woman, and that's not what I'm saying, I'm just saying, if you're one of those people who that's what you believe, then you've got to also realize the majority of women who have abortion are already mothers. And I mean, almost 60%. Right? It's like 59.89% are already mothers. And for whatever reason, they either cannot afford. This is not a decision that is taken lightly by women. And this is also unprotected sex does not necessarily mean that someone was reckless or what have you. And then my last point to this that goes just across the board is just something to think about. Women, are expected in modern society to be a little bit more experimental when it comes to sex, but still not be promiscuous. Yet men are expected to be promiscuous in modern society, but not experimental. And this becomes problematic when we start to think about what happens if we're thinking heterosexual, and I'm not only but if we're thinking heterosexual, this becomes problematic when we think about heterosexual sex and what the outcomes could be, because this becomes problematic in whether or not men choose to use contraception, and as well as when women choose to use contraception and what forms they use. Because men right now typically only have condoms as their primary source of contraception, most men do not consider getting a vasectomy, which is in most cases reversible, and in most cases give them less side effects than the array of contraceptive options that are available to women. So we can't think about this in terms of they had unprotected sex and they want to have an abortion and it might have been a reckless choice, when you go back to the fact that the majority, not the majority, but that a number of women who have abortions are married or already are mothers. This is more than just, I didn't think about what I was doing.
Any other comments on that?
I have to just represent the audience here because we had an outpouring of reaction to Frank's comment. So let me just say, we have people who've said, it doesn't matter what the reason is, access to healthcare is a right. We have people who say, contraception fails. It's not perfect. You can make all the best decisions in the world and still end up with a pregnancy. So people have very strong views about this. I'm sorry, go ahead with the panel.
Jessica, another comment?
The comment is just that I also want to say they've surveyed patients seeking abortion before, and the majority associate themselves as Catholic or Christian. So that meaning to just say is the morality and ethics discussion is very complex around abortion, and I respect a lot of views. I accept there are a lot of views out there. But at the end, I look at my patient, I see them in front of me. They're asking me for a medically necessitated procedure, and I cannot override their autonomy to consider, a view that is beyond what they consent doing to their body. So at the end of the day, as their physician, I have to honor what they're telling me and their wants and desires for their life. And that's my medical code.
Great answer. Alex, since we're at noon, why don't you get to one or two more questions before we terminate?
A couple of quick things. We've got someone who's asking, do we already, and maybe do we even more now, need additional comprehensive care clinics? Is that an issue? I mean, was that an issue before this ruling, or is it just an issue now that we expect we may have more patients?
Baltimore is lucky. 67% of the counties in Maryland don't have access to comprehensive sexual reproductive health for women. Primarily, as Jessica mentioned, the Eastern Shore, but we also have issues in rural Western Maryland. So the access is still problematic, and that was a problem prior to this ruling.
Okay. And a question came in, and this you may not be able to answer. It also, many of these questions require sort of a legal understanding or particular laws and states are involved. But IVF has come up a number of times because in IVF, very often you have, embryos that are frozen or that are discarded, that are not used, and some people consider that to be something that concern may be considered illegal in some states. Is that a discussion that anyone has been part of?
If I can speak, I just know my colleagues in IVF medicine are definitely thinking about this topic. I will point out that the population that unfortunately is the only population that typically access IVF is those of usually white privileged populations. So I have a feeling that legislature may not, pursue this in the way that it's pursued abortion, which has been more stigmatized and more needed by populations of color. So anything is up for grabs because this decision has been overturned, but I think there's going to be less incentive to pursue certain medical procedures because of the populations that have historically accessed them.
Okay, Alex, do you have one or maybe two more questions and then we'll call it a day?
Well, there was sort of one collection, and this has come up, we've talked about it a little bit, but many people are asking how they can help, how they can get involved to help people who are out of state, or how they can advocate for things that we could be doing in Maryland to help people out of state. So there are many different versions of that question, but if you have thoughts about that, I think that would be helpful to the audience.
Who has a thought on that? Dr. Cato.
I just have a few thoughts. One is don't try to reinvent the wheel. real. As several of us have mentioned, many organizers, particularly Black women, Indigenous women, other women of color, have been at the forefront of these discussions for decades, mobilizing for access to reproductive care. And so what I would say is to ask those local organizations what you need to do to help and support, and be consistent in that support. Donate to your local abortion funds, not Planned Parenthood, to your local abortion funds that actually provide the vast majority of abortion care for women in this country. And so I would say those are two very clear, concrete ways that you can support. And the third is to hold your legislatures accountable, not just for reproductive justice, but for healthcare justice more broadly, and to really center access to healthcare with reproductive care as part and parcel of that, as central to our rights as human beings.
Can I ask you a question on what you just said? So what kind of grade do you give the state of Maryland overall in reproductive health? Any of you is fine. I just am curious what your view is. I thought it was pretty progressive, actually.
In terms of laws, it's progressive. In terms of access, it is not. So I think that's where the sticky wicket is that, you know, if you want to just look and say Maryland has great laws, yeah, it's an A, and we haven't quite codified abortion, but we're pretty close to it. But in terms of access, we have an accessibility problem. And until this Abortion Care Act that just passed, a lot of people couldn't even use some of their insurance to access and obtain an abortion, even if they had insurance, right? So the law just passed, but now, as I mentioned, the messaging needs to go out to tell people you can get it, your insurance will cover it, you know. And then the next level still is those 67%. That's a lot of counties where people don't have access. And so, yes, the law says you can do it, but if you can't go anywhere, you might as well be in Texas, because you're driving. Maryland's a pretty big state. You're driving very far. I mean, it takes me, depending on, you know, the part of Western Maryland I'm going out to. We've done trainings for foster parents and child welfare workers in Western Maryland, and it took me 4 hours. So if it's taking me 4 hours to get there to train them on broad contraceptive access for their foster parents and their child welfare workers who are working with youth that are susceptible to adolescent pregnancy, it's also going to, for some of them, take just as long if the child, you know, youth, adolescent, and I'm using that term broadly and widely, does need to get contraceptive care or, you know, or even an abortion. That's problematic.
Yeah. And so that's an area to put your emphasis on. I would point out, over the last 2 years, something that we never used to use called telehealth now became standard. And one of the reasons it became standard is because it got paid for. The third-party payers paid for it. And so I think there's a number of approaches here to keep pressure on this particular topic. Dr. Cato, you look like you wanted to make one parting comment on this.
Oh, I was actually just typing in the chat the website URL for a national collective of local abortion funds, if folks want to look into them as a direct way that people can support our colleagues in states that are going to be most directly impacted, and their patients.
Terrific. Alex, let's do one more short question, and then we'll finish things off.
Well, I don't think I have a short question, except so at one point, Stacey, you mentioned a Title X clinic, and what is a Title X clinic?
Those are clinics that are in Baltimore, actually across the city, who are receiving funding, Title X funding through the federal government, to ensure that services are available to women to receive everything from breast exams to pap smears, and also family planning and contraception. So just making sure that those that funding exists, and that those clinics are able to serve some of our most vulnerable citizens. Mm-hmm. I also want to raise this whole thing around the importance of mental health and stress. I can't stress it enough. So we've been talking a lot about the providing and the provisions for the actual abortion. And so there's a piece around considering the mental health of folks who are receiving services that's embedded in reproductive healthcare services. And so that's critical. That's critical to be considered. We need to continue to support providers, mental health clinicians who are providing care through telehealth. And also we found that some folks really want to receive services in person as well. And so if we've learned nothing else from the continued fallout from the pandemic, is that pregnancy is isolating. Pregnancy has exacerbated mental health conditions, substance use conditions, right? And so all of that is in play when folks are making decisions around the best choices for themselves and their families.
Great. Well, this has been a very inspiring discussion. I've learned a lot. I appreciate very much your perspectives on this. I will tell you that you've kept your audience. We still have close to 300 on the WebEx, which is really a remarkable accomplishment. So people are obviously interested in this. This won't be the last discussion we have. And I think as one of you mentioned, hopefully there will be further discussions around this campus on these important topics. So with that, I want to thank you very much for being here. I want to thank the audience for your questions and your attendance. Again, we'll have more to follow. So thank you and best to everyone.